Okay, welcome to the webinar for today. Uh, today I'm going to give you a talk about just an overview of brainstem auditory evoked potential, or ABR, also known as ABR, auditory brainstem response, or brainstem auditory evoked potential, BAEP. They are also known as brainstem auditory evoked response, BAER. So the same, different names for the same testing. So I'll go over the anatomy and physiology, something about electrophysiology, the waveform, the different diseases, the surgeries, definition about the sounds during this talk. So anatomy of the ear. So the first topic is the anatomy of the ear. The ear has three parts known as external ear, middle ear, and inner ear. So in this picture, you can see so I have external ear, middle ear, and inner ear. So we can see in this picture, the orange on the left side is the external ear, which includes the auricle, or known as pinna, the tragus part, and the lobule, and the external auditory canal. They all form the external ear. So the external ear is the pinna and the auricle. There's external auditory meatus. That's the opening of the external auditory canal. The external auditory canal and tympanic membrane at the end of the external ear inside, and the tympanic membrane, which separates the external ear from the middle ear. The sound is collected by the pinna or the auricle. The sound waves come and they hit the auricle, and they're transmitted to the auditory canal, and they're channeled to the external auditory canal toward the tympanic membrane. The middle ear is the air-filled cavity behind the tympanic membrane. So we have eardrum here, which is also known as tympanic membrane, and behind that is the middle ear. There are three bones. There are three bones, or also known as ossicles, inside the middle ear: malleus, incus, and stapes. So malleus is also known as hammer. The first bone is malleus, which is attached to the tympanic membrane. The second one is incus, also known as anvil, which is attached to malleus, which attached to malleus. And the last one is stapes. Stapes is the stirrup, which is tied to the oval window. So you have oval window most inside, and tympanic membrane outside, and between the two you have three bones. So malleus is attached to the tympanic membrane, and stapes is attached to the oval window, and the incus is the bone which attached to the between the two bones. So it's important to know the name of the bones, because we do monitoring in ENT surgery. Sometimes what happens if the patient has severe middle infection for a very long time, and these get damaged due to bone tumors or other reasons. So what they do is they're known as ossicle chain reconstruction. So they take out the bones, these three bones, and put that implant another bone. So Eustachian tube is which is in start from the nasopharynx, is attached. It opens inside the middle ear, and that's one of the reason we get a lot of middle ear infection, because everything you have flu, especially this season we have flu. Everyone is having flu and cough and runny nose. The fluid travels up to the the Eustachian tube, and it accumulates into the middle ear and causing middle ear infection, and that blocks the so you have very heavy ear. So middle ear, when the sound vibration strikes the tympanic membrane, it is converted into a sound wave into a mechanical movement. So the sound waves is mechanical energy, sound energy, which it is transmitted into a mechanical movement or mechanical energy, which is it causes the ossicle bones to move and cause vibration. And those vibration travels to the inner ear, which is fluid-filled cavity. So the stapes is attached to the oval window cochlea, and when it moves, it causes uh, activation of the cochlea and a transmission of the signal to the inner ear. The inner ear has multiple parts, vestibular organs, cochlea, and organ of Corti. The organ of Corti have a basilar membrane, inner and outer hair cells, and tectorial membranes. Those are the part of. So in this picture, you can see the green, this external auditory canal until the tympanic membrane. And so this is all external ear. The red part is the middle ear, which has incus, malleus, incus, and stapes. And stapes is attached to the oval window. And oval window is attached to the cochlea. So you have three semicircular canals and the cochlea, which is a circular shape. And the auditory nerve start from the cochlea. So you have two part of the auditory nerve, cochlear nerve and vestibular nerve. The cochlear nerve start from the cochlea, vestibular nerve start from the semicircular canal. And these two nerves combine and they form vestibulocochlear nerve. So people who have severe dizziness or vertigo, um, so the semicircular canal is responsible for the balance, cochlea is responsible for hearing. People have balance problem and they are not treated with the medicine. There's a surgery which is known as vestibular neurectomy is done, which is doing the craniotomy and cutting the vestibular nerve, which is a treatment of this dizziness or balance problem. And with the intraoperative monitoring, we can help in identifying the vestibular part versus cochlear part. What we do is we put the electrode on the nerve and we stimulate, and if you get a response, it's a cochlear part. If you don't get the response, that's the vestibular part of the nerve. So that's the inner ear. Again, it has two functions, hearing and equilibrium. Hearing, cochlea is responsible for hearing, and the cochlea has three components: scala vestibuli, scala tympani, and scala media. The equilibrium balance is labyrinth or vestibular part, also known as labyrinth. It has semicircular canal and the vestibule. I'll show you a picture here. So again, the inner ear has a bony labyrinth and membranous labyrinth. So the bony labyrinth is the bone shell outside, and it is surrounding a membranous labyrinth inside. So there's a bone outside, and and the membrane inside. So the bone has vestibular complex, semicircular canal, cochlea, and distal part of the membranous labyrinth has receptor within the fluid, and it contains fluid which is known as endolymph. There's another fluid outside, it's not perilymph, it's a CSF-like fluid between bony and membranous lymph. So there are two fluids. One is inside the membrane, one is outside the membrane and inside the bone. So the fluid between the bone and the membrane is known as perilymph. Peri means around, and the fluid inside the endolymph is known. The fluid inside the membranous part is known as endolymph. That's inside the cochlea. So if you look at the picture, so this is the whole cochlea here and semicircular canals, and the blue part is the bony part, which has the inside part is the orange part, which is the membranous part. And if you look at the membranous part, between the membranous part and the bony part, you have perilymph, and inside this membranous labyrinth is the perilymph. So those and that this disturbance in the fluid can cause dizziness, vertigo, and other issues. There are two membranes in the cochlea. The oval window is connected to the stapes and it reduces the sound vibration into the cochlea. So when the sound waves hit the tympanic membrane, it goes to the malleus, incus, and stapes. Then it hits the oval window, and the oval window causes vibration in the cochlea. So the movement of the oval window causes the movement of cochlea and ultimately resulting stimulation of the cochlear hair cell. So inside the cochlea, there's a basilar membrane, which is curved according to the shape of the cochlea, and on that membrane, the base part is the initial part, and the tip is a triangular longer shape, and the tip is at the end, and there are small hair cells. When the sound waves hit that membrane, it causes movement of the hair cells, and at the base of the hair cells, there are small nerve fibers and causes depolarization and activation of the cochlear nerve. So the blood supply, the main blood supply is all the arteries and vessels surrounding the brainstem, because the response is produced near the brainstem. So main artery is vertebro-basilar artery, anterior inferior cerebellar artery, posterior inferior cerebellar artery, superior cerebellar artery, and posterior cerebellar artery. And the other branches from AICA, which is anterior inferior cerebellar artery, there are two branches, labyrinthine artery go to the labyrinth part, and cochlear artery go to the cochlear part. So ischemia to any of these can result in hearing loss. So benefit of using the ABR or auditory evoked potential in the OR is during the cerebral pontine angle surgery, for acoustic neuroma resection, vestibular schwannoma, vascular decompression of facial nerve for hemifacial spasm surgeries, microvascular decompression of trigeminal nerve for trigeminal neuralgia, vestibular section of relief vertigo, endolymphatic sac decompression for treatment of Meniere disease, monitoring of brainstem integrity during brainstem tumor, skull-base meningioma, brainstem aneurysm clipping of AV malformation around the blood supply near the brainstem, arterial AVM formation, fourth ventricle tumor. So all those, we can use auditory evoked potential to help. So that was the anatomy. So going to the pathway, you have, as we mentioned, there are two parts of the auditory nerve. One is cochlear nerve and one is vestibular nerve. The cochlear nerve originates from cochlea and join the vestibular nerve to form the vestibulocochlear nerve. There are 7 peaks which are generated along the pathway. So the activation of the most distal part of the nerve creates the auditory nerve or wave 1. When the nerve enters, it travels to the bone and it enters in the cranial part, enters the CSF, and wave 2 is produced there. So the proximal nerve is or close to the cochlear nuclei creates wave 2. Superior auditory complex, wave 3 is produced there, and the lateral meniscus and inferior colliculus, wave 4 is produced. Wave 5 is inferior colliculus, wave 6 is medial geniculate body, and wave 7 in auditory cortex. So again, so I have cochlear nerve, the nerves enters the brain stem and then cross over. The few fibers they cross over, most fibers they cross over, few fibers remain on the ipsilateral side. So the nerves, it has projection to the both side. Again, we have wave peak 1, peak 2, peak 3, peak 4, peak 5, 6, 7, or wave 1 to 7. These waves are numbers and in Roman numbers, not in numerical. So what we're monitoring is common peaks 1 to 5, and obligate peaks are, according to guidelines, are wave 1, wave 3, and wave 5. So we have to monitor wave 1, wave 3, and wave 5. Largest peak is always, most of the time, is wave 5. We do inter-peak latency from 1 to 3 and 3 to 5 and 1 to 5, and also wave 5 to wave 1 ratio. Those are the monitoring techniques. So talking about the sound, the definitions, we have decibel hearing level HL, which is also known as hearing level, stimulation intensity above auditory threshold of a large group of adults. So if you do, if you test a large group of the adults, so the threshold for at which they can hear, the average threshold is known as hearing level, and it's reference to audiometric 0 sensation, and which is sensation level. So 0 decibel hearing HL is equal to the threshold of hearing for a large group of adults. Auditory threshold intensity of a single person is known as dBSL, or decibel sensation level. So sensation level is for one person and hearing level is for a large group of people. Sound pressure level, another terminology used for sound, is dBSPL, or sound pressure level, is absolute pressure value of auditory stimulation, and it refers to the pressure of 20 micropascals, which is also 0.002 dynes per square centimeter. Peak equivalent SPL or dBPE-SPL is absolute pressure value of auditory stimulation. This is a so if you have uh, um, if you have a pure tone and a click sound and you stimulate with both of them and you're looking at a monitor, the sound level at which the peak click is equal to the pure tone is known as peak equivalent sound pressure level. Frequency is number of cycles per second. The high frequency sound are deflected from the membrane at the base of the cochlea, and low frequency waves travel to the apex of the cochlea. So if you look at the cochlea, it's a circular canal, circular shape, and the base of the membrane is at the beginning of the cochlea, and if you, the tip is at the most inner part. So high frequency sound waves, uh, if you know the so the this one picture in this, so in B we have pictures insert B C D. So in B you can see that the basilar membrane is a long triangular shape, uh, and the high frequency sound waves from 1500 to 20,000 hertz, they have very low amplitude. So when they come and they touch the basilar membrane, they affect the base of the basilar membrane. The medium frequency sound wave from 600 to 1500, they are picked up by the middle part of the basilar membrane, and low frequency 200 to 600 hertz, they are uh, at the apex or tip of the basilar membrane. So that's one of the reasons people who are exposed to very high frequency sound or very loud sounds, concert music, so they have damage to the basilar membrane at the base of the base of the basilar membrane is affected because that's the high frequency hearing loss. So when we are recording the auditory evoked potential, we have three types of recording that we can do. Number one is known as electrocochleogram or E-cog. The amplitude is about 2 to 20 microvolt, and there are three components of electrocochleogram. Number one is cochlear microphonic or CM. It is due to cochlear activation by acoustic stimulation. Number two is summation potential. It is cochlear activation by acoustic stimulation also, but it's consistent with presence of cochlear perfusion. So if the cochlear perfusion is affected, you'll see the change in summation potential. The number three is compound action potential, which is initial activation of myelinated segment of auditory nerve, and it produces a wave which is known as N1. Has the same latency of wave 1 of ABR, but is not wave 1. It is known as compound action potential. The second response that we can record is known as ANCAP or auditory nerve compound action potential. It's a high amplitude response, about 50 microvolt. It is directly recorded from auditory nerve. So you can put a Kuva electrode or a hook electrode or cotton width electrode right on exposed cochlear nerve or vestibular cochlear nerve in the brainstem area and record the response. It's a near field response with N1, and it has the same latency as wave 2 because wave 2 is produced from CPA angle, and NCAP is recorded from CPA area, but it is not considered as wave 2, it is considered as NCAP. The third one is brainstem auditory response, BAERS. The amplitude is very small, it's about 0.5 microvolt, 0.2 to 0.5 microvolt, and the wave recorded by three electrodes, and they are referenced to each other. One is on the vertex and two near the left and right ear. They're wave 1 to wave 7. So touching the guidelines are published long time ago and they've been revised every 5 to 10 years. So according to guideline 9C, which is about short latency auditory evoked potential, the stimulation and recording techniques. So for stimulation of auditory evoked potential, it is recommended to use a broadband clicks. Broadband clicks, uh, it's the acoustic energy of which spread over the wide range of audio frequency and used for the neurologic application of auditory evoked potential. So intraoperatively, we're using broadband clicks, and that's in the range of 2000 to 4000 hertz. These clicks should be generated by driving a 100 microsecond rectangular pulse. It has to be 100 microsecond pulse, single monophasic pulse, and should be used by ear insert. The short latency auditive evoked potential, or also known as SAEP SAPs, are electrical responses of auditory pathway that occurs within 10 to 15 milliseconds of appropriate acoustic stimulation. So this ABR or Baird signal we record, they are known as short latency auditory evoked potential, and the range is between within 10 to 15 milliseconds of stimulation. There are two type of again, one is E-cog and the other one is brainstem auditory or BEP. So E-cog and ABR are both are considered as short latency. So the guidelines, according to guidelines, they're if you stimulate the ear, we can get early response, a middle response, and late auditory response. The short latency auditory potential or SAPs are likely to respond within 15 milliseconds. So these are wave 1, 2, 3, 4, 5. Those are occurring within first 15 milliseconds. The middle latency, they occur from about 8, 9 to 25 milliseconds. Within 25 milliseconds, those are middle latency responses. And after 25 milliseconds, about 35, 40 milliseconds, those are long, late latency auditory responses. So electrocochleogram is it's a recording of a peripheral response. Just like when you're doing SSAP, we have upper SS per Earth point and Populi fossa for lower SSAP. ECOG is used as a peripheral response, which can give us information about the cochlea. If you have changes in the ABR, you can compare, also look at the ECOG and see if the ECOG is still there. That means that there's no stimulation failure, there's no cochlear ischemia, there's no blood loss to the cochlea, there is no obstruction to the cochlea. So the problem is after the cochlea, retrocochlea. But if the ECOG is gone, then that means that all those factors can be the reason, not because of damage to the nerve during surgery. So again, look in this picture, we have summation potential, we have N1, N2, and at the bottom trace, we have wave 1, 2, wave 5, wave 5, 6, and 7. So for ECOG, there are tympanic membrane electrode. You can use a needle going through the tympanic membrane, place on the promontory, or we can put again same thing, electrode behind the tympanic membrane. This is very invasive technique, putting a needle through the tympanic membrane, and should be done by ENT surgeon. The other method is putting this Tiptrode electrode. So Tiptrode is electrode is a gold foil. It's a gold foil which is present, which is placed on top of the regular foam insert, and it has a small connector and which is connected to the wire, and the wire is plugged into the regular head box, and so you can stimulate from this auditory stimulation, and you can also record from the same. So it's stimulation auditory, and this is touching the tympanic membrane, so you can do a good electrocochleogram using the Tiptrode electrode. The third option is putting cotton with electrode. But cotton with electrode is a cotton and it has a thin wire inside, so you have to dip into cold saline and then put against the tympanic membrane and then place the ear insert. So brainstem responses are responsive from the auditory nerve, brainstem, and higher subcortical area. Most of the audit have multiple sources. They are known as vertex positive responses, and vertex negative responses are the responses going downward. So all the responses going upward, they are known as vertex positive. Wave 1, 2, 3, 4, 5, 6, 7, and all the waves going down, they are known vertex negatives, and they are labeled as prime, 1 prime, 2 prime, 3 prime, 1 to 6 prime. So the vertex positivity and negativity has nothing to do with the real signal polarity. It is just how they are displayed on the screen. So for the stimulation, it is recommended again to use broadband click. The broadband click is a 2000 to 4000 hertz signal and 100 microseconds. It is a click stimulation, and the other stimulation that can be used burst, tone pips, filter clicks, single cycle clicks. So those are all different tests we can use that, but we don't use in the intraoperative. So intraoperative we use just, and there are three different type of stimulation. Actually two, and then third is combination. One is rare fraction. The first picture in this picture, so you can see the first one is R is the rare fraction, which is a negative peak. This causes hyperpolarization of the membrane. The second one is depolarization. It is a condensation, and the third one is the combination of the rarefaction and condensation, and known as alternating. So stimulus polarity of the first and most prominent wave is so we can do a rarefaction and condensation. So if you use a rarefaction, it causes the drum the drum of the stimulator, or also known as actually receivers, to move away from the eardrum. When it moves away from the eardrum, it causes hyperpolarization followed by depolarization, compared to decondensation, which causes the drum of the receiver to move toward the eardrum on tympanic membrane and causes the tympanic membrane to move away from the receiver and causes depolarization. So the latency, the peaks, um, uh, if you look at it, this cochlear microphonic, they invert the polarity. The summation potential does not invert the polarity with rarefaction condensation, but cochlear microphonic invert the polarity. So if you have very huge stimulation artifact, you can use alternating grid to cancel out, but normally you should not be using both of them. Either you should use rarefaction or condensation. The rarefaction is a hyperpolarization followed by depolarization, so the latency is a little bit longer compared to condensation. The condensation peak produces a larger wave 5. Rarefaction produces a larger wave 1. So if you want to have a better wave 5, you should always start with the condensation click. So as just a diagram, so you have the acoustic stimulation. In the rarefaction, the drum is moving, the tympanic is moving outside, then inside. In condensation, the eardrum moves inside, then outside, and alternating, it moves in and out. For stimulation parameters, the stimulator rates employed um, can, can be done from 5 to 200 hertz, depending what type of test you're doing. But for intraoperative use, we use 8 to 10 hertz, or less than 25 hertz. So anything less than 25 hertz is fine in intraoperative. You can go as high as 31 to 41, 42, but that can attenuate the signal. This amplitude of the responses gets smaller, and wave 5 get delayed if you're stimulating higher than 25 hertz. The stimulation intensity, it is recommended that click intensity calibrated in peak equivalent SPL, and we are stimulating. So we are stimulating between 80 to 100 decibel. So you have option of stimulating both mono-oral or bi-oral. It is according to guidelines, it's recommended you should always do mono-oral. Don't stimulate both ear together. Stimulate one ear and then the other, alternating to avoid any contamination. There should be a contralateral masking. It is the contralateral masking is a white noise about 60 decibel to eliminate the crossover response. And so if you're stimulating one ear, the other ear should be stimulated at about 60 hertz. So why we are doing contralateral masking? So little touching about contralateral masking, when the sound are presented to one ear through the earphone, the sound primarily stimulates the ear alone. So if you're stimulating with the sound is stimulating. But the high density sound also causes skull vibration. So the bone also vibrates and it causes stimulation or activation of the cochlea in the other. So the vibration of the bone transmit to the other contralateral side and can activate the cochlea. So this type of sound reaching to the other side to the bone is known as bone conduction and usually occur above at or above 30 to 40 decibel SPL for regular headphones and 60 decibel for insert phone. So cross stimulation over, so using a cross stimulation can be prevented by using masking. Masking is a white noise, is a continuous sound, and it blocks the uh, conduction of the sound from the bone. So according to the ACNS guidelines, the white noise should be at least 860 decibel to eliminate because the threshold of the bone conduction using headphone is 30-40 decibel, but using ear insert is 60 decibel. So using less than 60 decibel, then you will not cause the complete masking. So 60 or 65 decibel will be the ideal. So recording, so for recording for the auditory signal, the band pass should be between the low cut should be about 10 to 30 hertz, and high cut should be 2.5 kilohertz to 3 kilohertz, and the roll off should not be not exceeding 12 decibel per octave for low frequency. The analysis time should be 10 to 15 because they are short latency. So you have short latency, middle latency, long latency, ABR, and ECOG. They are short latency responses. So the analysis time should be 10 to 15 millisecond window, which is 1 to 1.5 millisecond per division. So the size of window should be 1 to 1.5 millisecond maximum. So we can record all the signal. The number of trial, again, the number of trial can be used as low as 1,000 and as high as 4,000. Using very high number can make the signal much better, get rid of noise, but it will take a very long time. And so interpretatory for the clinical, the non-patients are vague, you have EMG artifact, EEG artifact, and the other noises. So you will have to use a higher averaging. But intraoperatively, because the patient is asleep and the time is critical, so 1,000 to 2,000 averages will be enough. The electrodes, there are 3 electrodes which are used. One is placed on the scalp at CZ position according to the 1020 system. The 2 other electrodes, they are put at A1 and A2 locations. A1 and A2 location is the area in front of the tragus. It is not at the earlobe. So please don't put the A1 electrode on the earlobes because earlobes, they are not close to any nerve and you will have very poor responses and you will not, the only electrode will be CZ and you will be recording wave 1, wave 2 from CZ. It's very hard. If it is uh, if it is a surgical side or difficult to put the electrode, the alternate side is M1, M2. So you can do M1, M2 to CZ. So channel 1 is typically used vertex ipsilateral earlobe, CZ-A1 or CZ to M ipsilateral mastoid, and channel 2 should be CZ to contralateral AC or MC. ABR can be done in a wake patient and patient anesthesia. It can be recorded from neonate, infant, and adult. So this again, so criteria for abnormality, record or analyze primarily for the presence of wave 1, 3, and wave 5. So the guidelines say the measurement must include wave 1 peak latency, wave 1 peak latency, wave 3 peak latency, and wave 5 peak latency the inter-peak latency from 1 to 3 and 3 to 5 and 1 to 5. The amplitude of wave 1, the amplitude of wave 5, and 5 to or 4-5 complex to wave 1 ratio. So those are recommended values. And every time you're doing ABR, so you just make sure when you take the baseline, you enter those values. And not only looking for just wave 1, wave 5. It's also a good idea to add um, A1, A2 channels, which will show you a very good wave 1, but not wave 3, wave 5, wave 4 or 5. So any changes in those amplitude or interpeak latency will create an alert. So if there's a change in wave 1 to 3, that means the nerve is affected. If you change wave 3 to 5 is affected, that means the problem is in the brain. So before auditory evoked potential were used in the operating room, the incidence rate of hearing loss or hearing deficit was about 38% in US. In early 70s, the auditory evoked potential became common. The surgeons started using auditory evoked potential in the OR, and the incidence of the hearing loss dropped from 38% to almost less than 1%. So again, the stimulation rate should be 90 to 120 decibel per peak equivalent SPL. The rate should be less than 25 per second, and the contralateral masking should be more than 60 decibel per 60 decibel. So according to the guidelines, the abnormal ABR do not imply altered retrocochlear dysfunction. So criteria for retrocochlear dysfunction should include absence of all wave 1 to wave 5, absence of all wave following wave 1, 2, and 3, abnormal prolongation of wave 1 to 3 or 3 to 5 or 1 to 5, abnormal diminution of 4-5 or 1 to ratio, or abnormally increased difference between the two ears, so interauricular difference. So this is more clinical. So for hardware setup, so we have different type of ear insert. They are foam inserts, and they come in three sizes. One is the two sizes in yellow, one in beige color. The yellow has a extra large and the regular size, and the beige are pediatric size. So those are connected to the tubes, and we have two tubes. One is blue color, one is red color. They also come in both white color, but most commonly they are used in red and blue color. The blue should be used for the left ear. The red should be used for the right ear. So if you those tubes are about 10 inches long, and they they add a zero point 0.9 milliseconds latency delay because of the length. But if you select when you're doing ION system, you select ear insert, it automatically deducts 1 millisecond from the latency, and the latency shows on the normal value. So the sound is produced in these earphones. These are known as, they are also red and blue color. They are known as receivers, and the name receiver is originated from the old telephone. So if you have seen a very old telephone, which we have a big dial in front of it, it has a two-piece. One was known as one was known as receiver, and the other one was microphone. So the receiver was the one which you can hear and was producing sound. So that terminology is still used for this. So this is not known as stimulator, but these are known as receivers. So receivers, but they are creating the sound. And the summary again, the click duration 100 microsecond, rep rate about 8.1 to 21.1 hertz. Um, a wide multiple of 60 hertz, click intensity 90 to 100 decibel SPL, masking around 60 decibel. So rare fraction, condensation, alternating rate fraction is negativity followed by the positivity. Condensation is positivity or direct condensation. Depolarization. Wave 5 condensation always produce a better wave 5 or 5-4 complex, so you have to make it's always recommended to use condensation most of the time. So contralateral and ipsilateral auditory stimulation. So both ears should be stimulated. Both ears should be stimulated one at a time. Recording should be done by both ears. So you should stimulating the left side ear, the recording from the right ear. If stimulating the left ear, the recording from the right ear is actually a far field response from the left ear. It is not a right ear response. The purpose of using auditory evoked potential, you have three: neurological protection. So we do protection, cochlear protection, cranial nerve protection, and brainstem protection. So protection of the cochlea, the auditory nerve, and the brainstem. Those are the benefit of using auditory evoked potential in different types of surgery. Low cut 10 to 30 hertz, high cut 2500 to 3000 hertz, sweep about 10 to 15 millisecond, averages 1000 to 4000. Gain should be less than 2. Gain is the this gain is the dynamic range. It's not the sensitivity. So dynamic range again, when you look at writing the testing, the dynamic range is the window. So if you have gain of 10, 10 should be less than 10, but the according guideline it should be maximum 20. So if gain is 20 microvolt per division, then any signal about less than 200 microvolt will pass. So if your gain is smaller than signal, it will cause clipping. Display sensitivity should be about 0.2 to 0.5 microvolt per division. Reject should be set from anywhere from 10 to 75%, and notch filter should be always off in these cases. So again, we have A1, A2 electrode, we have CZ electrode, we have a ground electrode somewhere, and A1, A2 reference to CZ, or M1, M2 reference to CZ, and ground. So those are the three channels we use. So when you're setting up the program, so channel 1 we use CZ to A1, CZ to A2, A1 to A2, and CZ to cervical vertebra. Those are the 4 channels according to the guidelines. So on your display, so we can see wave 1, wave 2, wave 3, wave 4, 5. So if you're stimulating the left side, the wave 1 will be much prominent in the left electrode, but there will be no wave 2, wave 1 on the contralateral or A2 electrode. The 4-5 complex will be much more separate in the contralateral ear and will be merged or less prominent in the ipsilateral. The reason is that because the ipsilateral nerve is electrode is close to the nerve, so and contralateral is away, very far from the nerve, so you should not. And this is again exam question, CNM exam question. If you have a good wave 1 on the contralateral ear and poor on the ipsilateral ear, that means your electrodes are switched. Either the stimulators are switched or the recording electrodes are switched. The wave 4 and 5, they are produced on the contralateral side of the brainstem after crossover. That's why the contralateral ear produces a better 4-5 complex. The latency of wave 1 is about 2 milliseconds, wave 2 is 3 milliseconds, 3 is 4 milliseconds, 5 milliseconds, 6 milliseconds. And when you add a tube insert, it adds, this is after the tube insert. So if you don't use the tube insert, then it's about 1, 2, 3, or 4, 5. Wave 1 is about 1 millisecond, 3 milliseconds. But when you select ear insert in the software, it automatically deducts that, and wave 1 appears at 1 millisecond. It doesn't appear in 2 milliseconds. The inter-peak latency of 1 to 3 is about 2 milliseconds, 3 to 4, 5 is about 2 milliseconds, and the inter-peak latency from 1 to 5 is about 4 milliseconds. So again, we have wave 1, 2, 3, 4, 5, 6, 7. Wave 1 is produced close to the inner hair cell when deposition. First wave near the wave 1. Wave 2 is produced in the proximal auditory nerve. Wave 3 is produced in the ipsilateral side and contralateral side. It has superior auditory complex, and wave 4 is produced in the lateral lemniscus in the contralateral side. Wave 5 is produced in the inferior colliculus on the contralateral side. Wave 6 is produced in the medial geniculate in thalamus, and wave 7 is produced in auditory cortex. So wave 1 and 2 are ipsilateral, 4, 5 are 4, 5, 6, 7 are contralateral, and 3 is ipsilateral and contralateral. And the distance, so we're looking for absolute latency of 1, 3, 5, the interpeak from 1 to 3, 3 to 5, and 1 to 5, and the average amplitude of 5 to 1. So this is electrocochleography. So this is N1. So you have cochlear microphonics, submission potential, and you see those three responses when you do ECOG. ECOG is the electrode, is monopolar electrode, and this refers to the CZ electrode or FC electrode. So here we can see left ABR and the right ABR of one of the patient. The morphology is different on the right side and left side, and the amplitude is different. The latency is about 7.7 millisecond on the right side and about 6 millisecond on the less than 6 millisecond on the left side. You can see the wave 1 on the left side is much better, and 4-5 complex is much better on the other side. So in this one we have auditory nerve action potential, electrocochleogram, the second channel, and ABR on the third one. You have wave 1, 3, 2, 3, 4, 5. The latency of ECOG is about wave 1, and the latency of wave 2 is about nerve action potential. So these are the stack value of three electrical responses: A2 to FC, A2 to CPZ, A1 to CPZ, and A2 to A1. You can see you have clear wave 1, 3, 2, 3, 4, 5. On wave 4, 5 is present on the contralateral, but wave 1 is absent. On large channel, you have only wave 1. This one is not a very good signal, but a lot of noise in the beginning, and that's one of the reason is the microscope. So when microscope comes in, so it creates a lot of noise. We can see not very good wave 1. Wave 1 is present, but not as good as wave 5. So wave 5 is present, but it getting delayed a little bit, and then at the end it got disappeared. The surgeon was informed, um, and until closing, so it did cut back. So in the channel 1 and channel 2, both ABR, the wave 5 is getting delayed, you can see, and then it get uh, disappear. Total loss of wave ABR. So warning criteria: 1 millisecond increase in absolute latency of wave 1, 3, or 5, 1 millisecond increase in interpeak latency, or 50% decrease in wave 5 amplitude. So those are the warning criteria. So if it's a half millisecond increase in the latency of wave 5, then it is alert. So you have to alert the surgeon. But at 1 millisecond, you have to intervene. So if there's a delay of more than 1 millisecond or more for a very long time, for significant time, that predicts that patient will wake up hearing deficit. So even if wave 5 is present, and the signals are present, but if there's a delay of more than 1 millisecond for a longer period of time, that corresponds to loss of hearing clinically. So SSCP and EEG also very useful when the brain spin at risk. In addition to ABR, ipsilateral, contralateral are reference to site of auditory stimulation. Drilling in bipolar. So when surgeon is drilling, because it's a pneumatic drill, it's a sound, it causes contamination of signals. So you have to pause the stimulation. The changes in ABR can be due to vascular occlusion. It can be due to cerebellum and dural retraction, tumor retraction, direct nerve stretching, and compression. There are multiple causes. So abnormal criteria, the reversible loss of ABR is compatible with complete neurological recovery. Persistent loss of BAP or ABR is compatible with persistent neurological deficit. The correlation between ABR changes and associated clinical findings are listed in this graph. So if there's a transient latency increase, it could be because of drilling, irrigation, retraction, surgical irritation, hypocarbia and hypertension position. So keep an eye on your CO2 level. So if there's a hypocarbia less than 20 millimeter mercury CO2 level, it can cause vasoconstriction and cause changes in ABR. Persistent latency increase. It is usually due to retraction or pressure on the auditory tract. Transient loss of response could be because of retraction, pressure, or surgical distension. Permanent loss of oscillator response, surgical interruption of the auditory nerve, and loss of contralateral is usually due to cerebellar edema. There are various diseases that can affect the signal. There are the pre-existing pathologies such as multiple sclerosis or conductive hearing loss can be due to earwax, foreign bodies in the ear, osteoma, otitis externa, or otitis media. The sensory hearing loss could be because of Meniere's disease, presbycusis, which is hearing loss due to old age, ototoxic drug, um, uh, especially drugs that's for tuberculosis, they can cause hearing loss, and there's some other drugs they can also cause that. Trauma to the ear, diabetes, schwannoma, CP angle meningioma, hemangioblastoma. These are all they cause sensory neural hearing loss. So cochlear dysfunction is usually loss of hair cells in basal portion of the cochlea due to high frequency loss. So if you are exposed to very loud noise for a long period of time or for many years, it causes a loss of hair cells in basal portion of the cochlea, and it's also common due to in aging population and exposure to loud noise. It can also be caused by a tumor. So the cochlear these are the factors which is due to cochlear dysfunction. And if you have cochlear dysfunction, then you'll have loss of all the wave 1 to 5 or changes in the latency. The retrocochlear dysfunction could be absence of all wave 1 to wave 5. They can manifest, the issue is retrocochlear, not in the cochlea, but that can cause loss of all the waves from one. It can also cause absence of wave following wave 1 or wave 2 or wave 3. It can also cause abnormal prolongation of interpeak latencies or abnormal diminution of wave 5 to ratio. It can also cause abnormal increase in difference between two ears, intra-auricular difference in regard to wave 1, wave 3, interpeak 1 to 3, 3 to 5, or 1 to 5 interpeak latency. For data interpretation, we have conductive hearing loss and sensory neural hearing loss. In conductive hearing loss, all the absolute latencies will be increased. The absolute value of all the peaks will be increased, but the interpeak latency will be normal, because the problem is the conduction before the cochlea. So once the signal reaches the cochlea, there's no change difference. So 1 to 3, 3 to 5, and 1 to 5 remain same, but all the waves will be delayed. On the other hand, the sensory neural hearing loss, the increased wave 3, in increase in wave 3 or wave 5 latency, it can increase in interpeak latency of 1 to 3 or 3 to 5, and it could be due to auditory nerve lesions such as acoustic neuroma or brainstem tumors, CPA tumors. So this is one of the example where left versus right ABR responses. You can see a peak attenuation and increase in latency of wave 5 on the right side. The data matches the clinical findings due to right side acoustic neuroma. So this patient has acoustic neuroma, and you can see the difference between the delayed wave 5 on the right side. So this is data from stack of auditory evoked potential during a microvascular decompression of trigeminal nerve, and the manipulation of vessel of the cranial nerve 5 caused loss of wave 5. Re-exploration of further decompression of wave 8 restored the wave 5. So wave 5 was delayed, and then it was gone, and the surgeon was informed, it was re-explored, and the signal came back and came close to the baseline. So if the signals are plugged in wrong, the inputs, active reference they're plugged, you can also see the signal upside down. So you have to be careful, because if you're not aware of that, you'll be looking for all the up peaks, and actually you'll be those vertex positive peaks are actually vertex negative peaks. So cranial nerve 8 changes can be seen by uh, the proximal or entry zone damage, the area where the nerves exit the brainstem. If there is a sectioning of the eighth nerve or damage to the nerve at that area, that can cause that loss of the responses. So the data set stack value of ABR during the posterior. During this procedure, the proximal and distal component of oscillator cranial nerve 7 were cut. Loss of A1 was noticed after distal cranial nerve resection. So when the cranial nerve 7 was cut, you can see a stack here, and then all the wave 5 was not present on CZA1 on the left side, but wave 5 is gone and this totally disappeared. On on the right side, A2, A1, there's no change in wave 1, wave 3, or wave 5. I had mentioned earlier the vertigo auditory potential can be used for treatment of severe vertigo or dizziness. You can put a cotton wick electrode soak in the saline. If there's no monitoring, surgeon it's very difficult to differentiate the cochlear part versus vestibular part of the vestibular cochlear nerve. There's a slight color difference, yellowish and whitish on one side. Um, so it's more like a guess. So the dangerous part is that if you cut the wrong part and patient has dizziness and he comes with dizziness and you want to cut the what uh, vestibular part and the surgeon cut the cochlear part, patient will be dizzy and deaf. So that's like, okay, there's no going back then. So you can put the electrode on on the side of the nerve, and if you're stimulating uh, the ear, you can get a response. Like the first response is the cochlear part, so you can see a response. When you put on the vestibular part, there's no response. The cleavage is a part where the vestibular and cochlear part separates. And when you get close to that, you can see this is coming from brainstem to the nerve, so you can see response on both sides. And then on the cochlear part, you can see the response. Vestibular, there's no part, so it's much easier to identify the vestibular towards the cochlear. So electrocochleogram auditory nerve potential, there's no synapses, so they are very resistant to effective anesthesia. Brainstem responses are not affected by barbiturate, benzodiazepine, ketamine, nitrous oxide, propofol, muscle relaxant. Hallucinator have a mild effect proportional to the dosage. So if you have very high doses, 1.5, 2 mag, then there's the effect on, but less than 1.5 or 1 mag, there's almost no effect on. Temperature below 35 degrees, there's a prolongation of latencies and also interpeak latencies. And it's a very good relationship. Every degree, 1 degree decrease in temperature, body temperature is equal to 1 millisecond increase in latency. So the temperature drops below 2 degree below 35 degrees centigrade, there will be 2 millisecond increase in wave 5 latency. So various type of surgery where we can use we can offer surgeon, we can have the protection of the cochlear nerve and the brainstem, a CPA tumor, acoustic neuroma, vestibular neurectomy, brainstem lesions carry malformation, forefundicular tumor, cortical tumor, macular decompression of 5-7 intracranial aneurysms, AVMs, coiling of the aneurysm near the brainstem, ICA, basal vertebral artery, or extracranial intracranial bypass. So that's just a picture of there are different approaches, surgical approaches that can be used. One is retrocochlear. Retrocochlear is approach where they're going from behind the cochlea. So the tumor is the facial nerve. This you can see the facial on the bottom picture, right side. You can see facial nerve, and the tumor is surrounding that. It's pushing the trigeminal nerve and auditory nerve downward. So you need to have facial nerve monitoring and ABR and trigeminal nerve in this case. Also, there's a middle fossa approach, there's a suboccipital approach, there's a translabyrinthine approach. So those are the other three approach. Retrosigmoid is going behind the sigmoid bone. also known as suboccipitally cranial. Translabyrinthine is the approach where uh, the surgeons go to the labyrinth and they resect, and has a very good visualization of the facial nerve. And it is typically done when the patient already have a hearing loss because the auditory nerve is sacrificed during these surgeries. So you go through the to the cochlea and and the labyrinth is damaged. Yeah, and resect the cochlear nerve. With this one, the incidence of CSF is reduced, but hearing is completely sacrificed in this approach. Drilling has again it has vibration, it has sound. Drill is is a pneumatic drill. It's not an electrical drill used for the removing of the bone, and it causes conduction through the bone and it causes contamination of the signal. So you have to stop. There are different type of injuries. We can have mechanical injury, ischemic injury, thermal injury. Mechanical injury can be due to avulsion of the nerve, compression of the nerve, cutting of the nerve, or stretching of the nerve. Ischemic injury could be due to occlusion of the cochlear artery or ICA, or dissection of ICA, or vasospasm of cochlear artery. If there's a vasospasm of the artery, if you tell the surgeon immediately, they can put a medicine, drops of pipervarine. Pipervarine is a vasodilator, and the vasodilator causes opening of the vessel and restoring the blood flow to the cochlea. If you don't do that, and there's a prolonged ischemia during the surgery, patient will wake up hearing deficit. And thermal injury due to the heat or cochlea. So the audiogram, they are used clinically, and you can plot the on x and y axis the decibels. So it has clinically the ABRs are tested with different frequencies from 100, 200 hertz to 8,000 hertz, and red is right, blue is left, and you can differentiate between conductive hearing loss or sensory neural loss or or mixed hearing loss. So the patient with a conductive hearing loss, they have due to middle infection, osteosclerosis, tympanic membrane perforation, sensorineural presbycusis, noise-reduced hearing loss, acoustic neuroma, tumors, brainstem tumors, and the third type of hearing loss is the mixed hearing loss, which the patient has conductive hearing loss and sensory neural hearing loss. So the closing, so multimodal, so this is the auditory evoked potential. We talk about our ABR, but multi-modality monitoring is the best way. So you cannot use only ABR for any case. It's always used in conjunction with the other, because every modality has advantages and disadvantages. So ABR is just monitoring the pathway of the auditory pathway, but other pathway, facial nerve, other nerves, brainstem, sensory pathway, motor pathway can be at risk. So we have to use other tests in addition to the auditory evoked potential. Okay, thank you. That was the summary of the auditory signals. If you have any questions, you can ask. If not, then you can ask question later, email.
Thanks, Faisal.
Yes.